very comprehensively. You tried to cover all the aspects in a short time. May I now request Dr. Saleema Begum to please come and give her talk. Dr. Saleema is a HBP surgeon. She did her initial training at AKU with us, and then she did her advanced training in HBP surgery in Birmingham, UK, and now she has returned to Pakistan and taking care of complex HBP procedures, and she's going to talk about the parenchymal sparing liver resection for colorectal liver metastasis defining limits. So please welcome Dr. Saleema Begum.
Assalamu alaikum all. Thank you very much, Dr. Rizwan, for the introduction. So I'm going to talk about parenchymal sparing liver resections for colorectal liver metastasis defining limits. So colorectal cancer is the third most common cancer and second most cancer-related deaths worldwide. Metastatic disease remains difficult to treat. However, it is not a contraindication for liver resection. Despite the advancements in advancing the clinical resectability of colorectal liver metastasis and advancements in adjuvant and neoadjuvant chemotherapies, metastatic disease still remains one of the common causes of death for colorectal liver metastasis patients. However, the surgical assessment should be obtained at initial time of diagnosis. So there are a lot of challenges that are faced, especially in countries where the incidence of colorectal liver metastasis is lower as compared to those where it is high, like in Western countries. So we have seen that in these countries, the management of colorectal liver metastasis is underutilized because most of these patients who have more than 2 or even more than 1 colorectal liver metastasis are referred to oncologists. And these are the patients who are actually should be considered for upfront resections, and 90% of these patients who end up with oncologists are actually candidates for upfront liver resection for colorectal disease. The other thing that is important to consider in these patients is the identification of the ideal operative window, because in advanced or in borderline resectable tumors, there is a role of neoadjuvant chemotherapy in downstaging these tumors and making them resectable. And then again, the treatment sequencing, because as I said, most of these patients usually ended up in oncologists, and these patients are started on adjuvant or neoadjuvant chemotherapies rather than getting upfront surgical review for resection. So this actually can compromise the overall survival of these patients. So the most important thing is to discuss these patients in hepatobiliary MDTs in presence of a hepatobiliary surgeon so that they can decide at the initial time of diagnosis about the surgical management of colorectal liver metastases. So if we classify the liver metastases, we have either upfront resectable, borderline, or unresectable disease. So 10% of these patients are actually are candidates of upfront resection, followed by borderline resectable tumors who are actually 20%. However, after conversion therapies, these can be surgical candidates. However, 70% of these colorectal liver metastases remains unresectable. So if we look at the upfront resectable criteria, if we have sufficient future liver remnant with at least 20% of healthy liver volume, these patients can have a major liver resection with possibility of an R-node resection. And these patients should have an adequate vascular inflow and outflow and biliary drainage. So according to recommendations, these patients should have an upfront liver resection rather than being referred to oncologists for chemotherapy. The second is borderline resectable tumors. So these patients have potentially resectable tumors. However, because of technical or biological challenges, these patients should be referred to oncologists for some neoadjuvant chemotherapy, followed by downstaging, and then offer them surgical resection. And the third remains the unresectable disease, which are around 70% of these patients who have bilobar disease involving all of liver segments. And if 2 segments are not salvageable, then these patients should only have a palliative chemotherapy. So if we look at the surgical management of colorectal liver metastasis, we have either resection or transplantation. So in resections, we have parenchymal sparing resections, single-stage hepatectomies, 2-stage hepatectomies, and ALF procedures. So in my today's talk, I'll be just concentrating upon the parenchymal sparing liver resections. So in last decades, a lot of hepatobiliary surgeons have been focusing on increasing the frontiers of resection for these colorectal liver metastases. And the paradigm has actually shifted from what is resected to what remains after resection. So the FLR that remains after resection, that is very important. And oncological surgeons should have a balance between two conflicting oncological ideas, which is the R0 resection versus to preserve liver parenchyma to avoid post-operative, post-hepatectomy liver failure. Because in around 7 to 10% of patients after major liver resections, these patients have higher rate of mortality because of liver decompensation, because of insufficient FLR. So whenever we offer major resections with aim of achieving an R0 resections, these people or these patients have major hepatectomies, including either right, left, or extended hepatectomies. But these procedures have substantial morbidities and mortalities. And the mortality after, as I said, post-hepatectomy liver failure is high as 7 to 10%. So although we do have certain strategies to improve the FLR or to downstage the tumors, including borderline bridging TACEs followed by resections, or conversion chemotherapy, which can downstage these tumors, or endovascular procedures, including ablation or TACE to downstage procedures. The other things that we can do to increase the future liver remnant could be portal vein embolization or total liver venous deprivation in the form of dual vein embolization, or surgical techniques including two-stage hepatectomies or ALPS procedures to increase the future liver remnant to decrease the chances of post-hepatectomy liver failure. So if we look about the parenchymal sparing liver surgery, so the aim of, or the idea behind this parenchymal sparing liver surgery is now colorectal liver metastasis is treated as a chronic disease rather than a metastatic disease. So we aim to have a management similar to Crohn's disease, where we try to resect less and keep more, so that if we need to resect or if there is a recurrence in the remnant liver, we'll go back and resect, because the overall survival after re-resections is significantly higher than those patients who just received chemotherapies for colorectal liver metastasis. So this idea comes from the first is the future liver remnant, and the second is the negative resection margin. So initially the aim of resection for colorectal metastasis was to achieve a resection margin of at least 1 centimeter. However, the idea has now changed, and a resection margin of as small as 1 millimeter is sufficient to gain the same oncological results as 1 centimeter margins. So if you look at the histological perspectives and oncological basis, the management of, specifically surgical management of colorectal liver metastasis depends on either tumor resectability and tumor biology. So in last few decades, the resectability and the management has evolved. Back in 1970s, only single metastatic lesion used to be the criteria for resection in case of liver metastasis. However, after at least 10 years, Addison et al. Found out that the overall survival and disease-free survival in patients who had multiple liver metastases after resection had similar overall survival as compared to a single focal lesion. In 1990s, Epkers found out that there are certain negative prognostic parameters that can actually decrease the chances of survival after resection, where more than 4 lesions, unilobar disease, and those who had poor response to chemotherapy. So these patients had poor prognosis after resections. So they excluded these patients from oncological liver resections for colorectal liver metastasis. However, the groundbreaking research was done by Pavlik et al., where he found out there is the width of negative margin does not impact survival in colorectal liver metastasis. So this was the study which was published, and this was a landmark study including 557 patients, where he found out that the negative margin resection does not, the width of negative margin resection does not actually impact the overall survival, where he compared negative resection margins of 1 into 4 mm, 5 to 9 mm, and more than 1 centimeter. And he found that the overall survival in all these patients was similar. Again, followed by that, there was a propensity score match analysis done in more than 2,000 patients, which also showed that 5-year overall survival was similar in 1 millimeter versus more than 1 millimeter, provided the response to adjuvant therapy is better. However, in those patients where the tumor biology is aggressive and they are not respondents to chemotherapy, the overall survival remains low. So contrary to historic 1 centimeter margin, as I said, even more than 1 mm margin is sufficient, and the survivals are actually equivalent. So the expected close margin, especially when tumor is close to vital vessels, including hepatic veins or portal vein, can even be accepted as R1, when there is microscopic tumor at the vascular margin, but the survival has been seen to be equivalent to those who had R0 survival, provided they are responsive to chemotherapies. So this is a particularly challenging situation where we have tumors at difficult locations. If we see here, so this is a difficult tumor which is just behind the middle hepatic vein at junction of the confluence of all hepatic veins. So in these cases, if this patient has to have an R0 resection, he would require a major central hepatectomy. However, in case of liver sparing techniques, we can actually scoop the tumor out from between the vessels and also accept an R1 margin at IVC or M1 with similar oncological outcomes as compared to those who have a major either extended hepatectomies or a central hepatectomy. So again, so this is a propensity score matching analysis which has shown no difference in overall and recurrence-free survival after R0 or R1 margins, especially at vascular margins and the tumors located at the confluence of 3 major hepatic veins. So second important prognostic factor is tumor biology. So tumor biology in case of colorectal liver metastasis is different, and its considerations are different as compared to hepatocellular carcinoma. In hepatocellular carcinoma, the tumor spread is usually along the portal triads. However, because of the hematogenous spread of colorectal liver metastasis, the anatomical resections are usually not required. And we have seen that the non-anatomical resections have equivalent results as compared to oncological and anatomical resections for colorectal liver metastases. So whenever we plan a patient for a parenchymal sparing liver resection, it is important that this patient should be discussed in hepatobiliary enmity in the presence of the operating surgeon, so as to devise the final operative strategy, which usually should involve the risk stratification of the patient, which involves the overall ECOG status, performance status, the fragility, and the technical resectability, which would be defined on the basis of imaging modalities, including triphasic CT scans, and then, of course, the oncological rationality, whether this patient is going to benefit from this resection or not, how is the tumor biology, and whether it is responsive to chemotherapy or not. So when we speak of imaging modalities, so triphasic CT scan is the standard of treatment and the standard modality for all colorectal liver metastases. It does not only give us the idea about the position and location, but also vascular anatomy, and it can also give a fair idea about the qualitative liver parenchyma. We can also use these scans for doing volumetry to assess the future liver remnant, and also the 3D reconstruction of vascular structures can actually help us understanding the vascular anatomy, and if any other aberrant anatomy exists, we can actually pre-plan the procedure according to that. The second is the MRI. So MRI is the modality of choice for lesions which are less than 1 centimeter. Apart from these sub-centimeter lesions, it is best for those patients who have received chemotherapy, because in around 18% of patients who has sub-centimeter lesions on CT scans are not picked up there, so they need subsequent MRIs to define and to identify these small lesions. So the intra-op ultrasound. So although the technicality of the resection or the operative planning is based on pre-operative imaging, however, in case of parenchymal sparing resections, intraoperative ultrasound is very important. This does not only help us strategize our operative planning, but also it can identify around 20 to 25% of lesions which are not identified on preoperative cross-sectional imaging. Apart from that, it can give us a crucial idea about the tumor location and its distance from these major vascular structures, and the feasibility of whether we can offer these patients parenchymal sparing resections, or these patients should undergo major hepatic resections. So as I said, so operative planning is very important. We just cannot list a patient for parenchymal sparing liver resection without proper operative planning, because these tumors are usually located at different positions and difficult positions, especially involving the outflows and inflows. These needs to be, the scans and the proper imaging needs to be studied preoperatively so as to devise a management plan for these patients. Apart from that, the FLR is very important. If we have not sufficient FLR for major resection, these patients need to be sent for an FLR calculation. And apart from CT volumetry, although it's not available, these patients should have functional scans, because apart from chemo-induced liver disease and obesity or NASH, these patients can have functionally hepatocytes which are not functionally well. However, their volumetry can be sufficient. So in order to calculate the functional assessment, these patients ideally should have functional scans before deciding on the exact operative procedure. So there are certain criteria that actually exclude certain patients from parenchymal sparing dissections. And again, these are those tumors that are located at the hepatic outflow or inflow. If the patients have tumors which are not separated by a thin rim of hepatic tissue between vein and the tumor, or if there is vessel wall discontinuation and the contacts exceed more than 1/3 of the diameter of the vessel wall, these patients should have anatomical resections rather than parenchymal sparing resections. And again, in case of inflow, if there is distal bile obstruction, or if the tumor is encroaching the Glisonian sheet more than 2/3, then these patients should be offered anatomical resections. So if we talk about surgical techniques, we should be precisely 100% clear about the anatomy and aberrant anatomies that exist in certain patients. So this is the normal anatomy of liver, where we have 3 hepatic veins: right hepatic vein, middle hepatic vein, and left hepatic vein. However, there are certain variations which are actually important in terms of parenchymal sparing dissections. You can see the inferior right hepatic vein, which is usually present in about 80 to 85% patients, and it can be a life-saving vein for certain patients who cannot undergo major resections because of decreased FLR. Similarly, again, these communicating veins between the 3 main hepatic veins, these are important if we are considering patients for parenchymal sparing liver resections. So just coming to certain scenarios where we can offer patients with parenchymal sparing resection. So this is the tumor sitting at the right hepatic vein confluence. So ideally, we usually, in a normal scenario, offer these patients a formal right hepatectomy. However, in case of parenchymal sparing resections, these patients can have a bisegmentectomy, resecting segment 8 and segment 5 in the presence of these communicating veins. We can actually sacrifice this right hepatic vein, but we do have communicating veins from left hepatic vein, so the venous drainage would not be compromised in this patient. Again, in the second scenario, if we have two lesions in segment 5 and 6, rather than giving a right hepatectomy, this patient can have a bisegmentectomy as a treatment of choice. So the second scenario, where we have two lesions where expectedly we usually offer a right hepatectomy. These patients can have a right posterior hepatectomy where we can save actually two segments. So again, this is the most difficult scenario where we have centrally located tumors just sitting on the middle hepatic veins. So rather than giving them extended left hepatectomy, these patients can be offered central hepatectomies. And there are different scenarios as well. So the last scenario that I would like to mention is, so these tumors, where we have multiple focal diseases, bilobar in right and left cases, we can give these patients non-anatomical resection, a central hepatectomy for these, and then if this is deep-seated lesion, we can offer them with ablative procedures concomitant with liver resections. So as I said, with the advancement in resectability, we can have a better multimodal therapy, and these patients can have a survival benefit equivalent to a major resection if we give the difficult lesions which are difficult locations can have ablative procedures like RFA or microwave with the same sittings, and again the results are equivalent. So the outcomes, the operative outcomes are less blood loss, less transfusions, length of stay is less as compared to major procedures, there is less 90-day mortality with no risk of PHLF. In case of oncological outcomes, there is no difference in overall or disease-free survival compared to anatomical resection. And again, the emphasis here is if they are responding to chemotherapy. So in conclusion, well, parenchymal sparing liver resections have been offered as a standard of care in major centers who have high volumes of colorectal liver metastasis. But the important thing is the profound knowledge of anatomy and intra-op ultrasound skills required to take these difficult decisions. So the negative margin resection is the key for better oncological outcomes. However, in difficult cases where we have vascular R1s, the oncological outcome still remains equivalent to those who have R0 resections. Thank you.
Thank you, Dr. Saleema. May I now request very quickly to Dr. Zeeshan to please come on the stage. And he's going to talk about the management of borderline and borderline resectable pancreatic cancer. Dr. Zeeshan is a hepatobiliary surgeon. He's an AKU alumni, and then he trained in US for his multi-organ transplant fellowship. Subsequently, he has spent a couple of years, I think, in Gumbat, and now he's with us at AKU, and he's routinely performing complex hepatobiliary surgery, and we are looking at liver transplant, Zeeshan, in the future, inshallah. So please welcome Dr. Zeeshan.
Thank you, Dr. Rizwan. I will be talking about essentially borderline resectable pancreatic cancers and locally advanced. Most of the concentration is going to be along the borderline pancreatic cancer. So I've categorized my talk into first defining borderline resectable, and then we're going to quickly go over some data regarding role of neoadjuvant treatment in these patients, and some quick review of more complex vascular arm block resections and what the data shows regarding those. So as we all know, pancreatic ductal adenocarcinoma, seems like the font has completely changed over here. Okay, anyways, pancreatic ductal adenocarcinoma seems to have poor prognosis, as we know, and that is essentially thought to be secondary to its aggressive biology and the tendency to grow subclinically, which is essentially not recognized. Most of them present as metastatic when they come to see us, and only 20% of these are actually resectable at presentation with the potential for upfront curative intent therapy, which is essentially surgery for these patients. The 5-year overall survival for these patients still seem to be pretty low. In the best case scenario, 32% for resectable patients, and that is essentially thought to be secondary to the early systemic involvement of the disease, which we don't recognize at the time of its clinical presentation. So the first challenge when we talk about resectable and what is borderline is defining it. And the initial goal in defining borderline resectable pancreatic cancers has been to identify individuals that are at a higher risk of not getting an R0 resection, which is what the goal is, and thus might benefit from some form of pre-operative treatment in order to achieve our goal. There's been significant differences in the publications of definition of borderline resectable, which I think over the course of the years has also negatively impacted the applicability of the trials that have been done. When we talk about borderline resectable, the term was first coined in 2006, and the essential, these are different definitions that we see that exist, and as we see there's a heterogeneity in these definitions. Initial definitions were all along the lines of the tumor and its interaction with the portal vein, the superior mesenteric vein, the common hepatic artery, or the superior mesenteric artery. However, differences exist within these definitions also as to the degree of involvement. And another thing I think that has gotten some criticism over the years is the ambiguity of the terms such as abutment or reconstructible in these definitions. So NCCN is what most centers consider standard when it comes to defining borderline, and the middle row is what we're looking at, where they've further subclassified borderline resectable into arterial and venous relations, and then different numbers or degrees that they've given to what we consider resectable. I think in essence the idea for the layman is to understand that whether we think for borderline it is something that we think is resectable and might require some sort of venous or arterial reconstruction, which is possible at that time. So this was a meeting that was done, the 20th meeting in 2016 of the International Association of Pancreatology, with the idea of goal was to achieve a uniform definition with unambiguous terms, and at the same time, other than just anatomy, introduce biological and conditional factors also. Biological factors such as CA19-9 levels and lymph node metastasis, which per data has shown an inverse relation with overall survival for or an R0 resection for these cancers. And then conditional factors such as performance status and comorbidities, which has shown poor overall survival in data. However, it remains to be seen whether this consensus definition will be widely used. None of the major consensus guidelines so far has been updated to include this definition. When we talk about management of pancreatic or borderline pancreatic cancer, we have different guidelines. These are the NICE guidelines from the UK, which were published in 2018, however, unfortunately have not been updated. And even over here in the latest guidelines, they do not consider neoadjuvant treatment for borderline pancreatic cancer outside of a clinical trial. And the second issue I think that I would like to highlight here is the intention to treat. I think there was a time when borderline resectable, locally advanced were considered as palliative diseases, and I think we'll go over some data where we think anything, well, now we need to, the intention to treat should be there for a cure for these patients. So NCCN guidelines is what's is the standards, especially in the US, and they, I think very clearly have categorized these patients requiring neoadjuvant treatment, followed by restaging and then resection. I will go over some data now which exists from the management of these borderline resectable patients. This is published in 2018 in the British Journal of Surgery by a Dutch group, where they compared neoadjuvant treatment versus upfront surgery with an intent to treat basis. And the primary outcome for this was overall survival, with the secondary outcome being resection rates of 0, pathological lymph nodes rate. They selected around 3,500 patients. 35 of these studies had neoadjuvant treatment, where 29 had chemoradiation and 6 had chemo alone, and 12 of these studies mentioned rates of upfront surgical or survival rates of upfront surgical resection. And what they essentially showed that the median overall survival for neoadjuvant chemotherapy patient that received neoadjuvant versus upfront surgery was 18 months versus 14 months. About 18% of these patients in the neoadjuvant therapy group did not have resection. However, out of the patients that were resected, the median overall survival for those that had gotten neoadjuvant treatment was much better, almost a year more than those that had not. And there was one counterintuitive finding where they said high resection rates in borderline resectable as opposed to the resectable group. But I think that again points out to the variation in definitions that are being used for which, and the centralization of the services, where I think some of the patients that were considered resectable actually had advanced disease. So moving on, I think, where did I go? This is another study which talks about primary chemotherapy in borderline resectable and locally advanced pancreatic cancer. All patients got neoadjuvant treatment. They enrolled, the aim was to evaluate the rate of chemotherapy and the treatment compliance and the rate of surgery and survival outcomes. And the chemotherapy regimens that were used were the modern ones where they were using FOLFIRINOX and GemCap. And I think essentially the median overall survival for patients was comparable. Resection rates in the groups that had gotten neoadjuvant was 24% in the borderline resectable group, which without chemotherapy is not as significant. What they concluded at the end was that completion of chemotherapy, addition of radiation therapy, and resection were independent factors that were associated with improved survival. This is another study that was published in 2020 with the US registry data, which included about 44,500 patients, and this was essentially comparing chemo to chemoradiation. They used a large number of patients with varying regimens of chemotherapy, and they showed better results with multi-agent chemotherapy and radiation therapy as opposed to radiation therapy alone. This was a trial, again, by the Dutch Pancreatic Cancer Group that was initially published in 2020, and then they showed their long-term outcome data. These were 16 high-volume centers over 4 years, a randomized controlled trial where they gave 3 cycles of GemCab followed by radiation, followed by adjuvant gemcitabine, where they restaged in the middle, obviously. And essentially, there were 120 patients who underwent neoadjuvant and radiation therapy, and 128 patients that underwent immediate surgery. And the primary endpoint was overall survival with the intention to treat. And although the median survival difference was 1.4 months initially, but on long-term follow-up, what they saw was that a 5-year overall survival was 20% for patients that had gotten neoadjuvant chemoradiation versus 6.5% for patients in these groups that underwent upfront surgery. This is another trial that was conducted to assess upfront surgery versus the 3 treatment modalities of different types of chemo and chemoradiation. This was a 4-arm prospective multi-center international randomized phase 2 trial where they compared surgery with neoadjuvant group. They had randomized stratification of 4 treatment, GemCap, FOLFIRINOX, chemoradiation, and surgery alone, where their primary outcome was essentially to figure out the recruitment rate and the resection rates, R1 and R0. And the secondary outcome, I think, is where it actually showed some results of overall survival. These were the number of patients that there were in each group, and then out of those, how many actually moved into the resection group. And initially, there was no significant difference in the resection rates amongst patients that underwent immediate surgery versus neoadjuvant treatment. As you can see in the first, it's not significant. However, the R0 resection for patients that actually underwent surgery, which is that other table, their R0, R0 resection seems to be better for patients that have gotten neoadjuvant treatment versus immediate surgery. It was this that I think essentially shows more of a difference. The overall survival for patients that underwent immediate surgery was 42% at 12 months as opposed to 77% for patients that had forgotten any sort of neoadjuvant treatment. And that the other graph essentially compares all these different trials where patient that got FOLFIRI had the best outcome, followed by patient that got GemCap as neoadjuvant, followed by patient that got chemoradiation, and at the end, patients that got just upfront surgery. So I think all in all, there's sufficient data and concluding evidence that says neoadjuvant treatment in these patients, especially for borderline resectable patients, improves the R0 resection rates, and at the same time, survival. And based on the last trial, which is still in the phase of moving on, it shows that probably FOLFIRI seems to be superior than GemCap in these patients. Moving from pre-treatment to actual resection, and I'm going to quickly go over, for the sake of time, some of the data that talks about resection. The study from South Korea basically was done with the aim to clarify the prognostic influence of venous resections. And what it showed was that these patients, 7 out of 106 patients, we'll go over the data actually, I'll just move to the tables. And they had essentially compared patients that underwent venous resections versus patients that did not undergo venous resections, and all of these patients got neoadjuvant treatment. And I think the last, oh sorry, this is not changing here. So the overall survival for venous resections versus no venous resection for all cases was relatively similar. Figure 2 essentially shows that patients who underwent portal vein resection had poor overall survival initially, but as time goes on is comparable to those that underwent portal vein or did not undergo portal vein resections. And most importantly, I think, is that last slide over there gives you the essence of pancreatic cancer surgery, is that regardless, for patients that had an R0 resection, they had the best overall survival. If they did not require a portal vein resection and still managed to get an R0, that was the best survival. Those that got portal vein resection but still and were able to get an R0 resection were the next ones. And following those portal vein resection or not, as long as they have a positive resection margin, the outcomes are worse. So at the end of the day, if you're able to achieve R0 resection, regardless of portal vein resection or not, it's better than getting an R1, which I think is pretty obvious. This is historically locally advanced pancreatic cancer was considered a palliative condition. And the aim was a systemic review that was published for the evidence of locally advanced pancreatic ductal carcinoma treatment strategies with curative intent. And essentially what it looked over all the data, this was essentially what it shows is that overall survival, the overall survival is 30 months for patients that underwent neoadjuvant treatment and surgery for locally advanced disease versus patients that did not undergo resection. So I think if we think resection is possible, we should still go for it because it does seem to have better outcomes. Another systemic review that looked at multiple 13 studies where there were arterial involvement and venous involvement requiring resections, and the median survival and disease-free survival for these patients after major resection is also around 17 months, which is comparable to the other groups. This is distal I'm going to skip over this. This talks about the Appleby procedure. This is another interesting article that was from Germany where they looked at about 200 patients with pancreatectomies requiring arterial resections. And I'm just going to concentrate on one aspect of it. They did talk about R0 resection rates, which were 28% for these patients. The median hospital stay was 15%. But another interesting thing that they looked at was that the mortality in patients that were undergoing major arterial resections for locally advanced pancreatic cancer seemed to decrease as the surgeon's experience or the team's experience increased. And they saw a turning point at around about the 15 case mark where a team or surgeon who has done 15 of these complex arterial resections for pancreatic cancers, the immediate mortality or the 30-day mortality for that particular group of patients seemed to improve beyond that. So I think coming towards the end, I just went over some data. I think important things when we talk about borderline resectable or locally advanced disease is that it remains to be seen whether we're going to come up with a uniform definition which is going to be broadly adopted. I think neoadjuvant treatment is the preferred method of treatment for borderline resectable pancreatic adenocarcinoma. The benefit of radiation, however, I think is still plus minus, given the fact that it makes the resection difficult post radiation, and the data that we've shown does not show a significant increase in the R0 resection with radiation, even though it has statistical significance. The numbers are not really that different. I think restaging following neoadjuvant treatment also is an ongoing challenge based on how it obscures the ability for us to assess whether there's involvement or not. I think another thing for surgeons is being a bit liberal about taking these patients actually to the OR with the intention to treat and then figure out whether we really think this is unresectable or not. And I think for pancreatic cancer, as we all agree, the goal lies in the understanding the disease process and the molecular underpinning of these cancers. And I think what has shown the best benefit for treatment or best treatment for these other than the operative intervention is the chemotherapeutic or the radiation approaches, which has actually improved survival over the course of decades. And for places that I think when we talk about en bloc resections or big cancer operations with vascular reconstruction, it needs to essentially be done at high volume centers with patient selection is very important. Biology is very important. So you need all hands on deck, and you need to have a plan A, B, C, and a plan to just abort at that point. Thank you.
Thank you, Dr. Zeeshan. Thank you very much. We move on. So we have talked about HCC, colorectal liver mets, and now pancreatic cancer. As we understand that radiology, interventional radiology and gastroenterology are part and parcel of the management of these complex problems. So now we have the next two speakers from these specialties. First, I would invite Dr. Junaid Iqbal. He's associate professor and interventional radiologist at Al Khan University. He's a regular member of our multidisciplinary liver cancer clinic, where we discuss all the liver cancer patients under one roof. We have surgeons, gastroenterologists, radiologists, oncologists, and all of us discuss to make a plan for an individual. And Dr. Junaid is a vital member of that team, and he's going to talk about not just all the contributions of radiology, which are so great, but he's just going to talk about the therapeutic ablation and hyperthermia in HBP cases. So thank you very much, Dr. Junaid.
Thank you, Dr. Rizwan. So I will be discussing the outcomes of therapeutic ablation and hyperthermia in hepatic, pancreatic, and biliary cancers. So I think a lot have been thing has been discussed. So hepatic, pancreatic, and biliary cancers are very common. Unfortunately, 70% diagnosed at advanced stages due to lack of early symptoms. Intervention radiology offers minimally invasive solutions with curative and palliative intent. And the introduction of ablation and hyperthermia technique as the part of intervention oncology has significantly shifted the paradigm of management. So the goal of the talk is highlight the outcomes and growing role of IR in this setting. Intervention radiology can provide the precise targeted treatment under image guidance. It has a shorter recovery. Most of the procedure can be performed as an outpatient, and it has a lower complication rates. So main therapies include the ablation, embolization, and hyperthermia. Among ablation techniques, RF and microwaves are included for HCC, pancreatic, as well as for biliary tumors, while embolization, which is actually not the topic of this discussion, but embolization include the TACE, tear, especially for advanced and intermediate stage tumors. And hyperthermia is another management which enhances the chemotherapy and radiation requirement, and it explored in pancreatic and biliary malignancies. So overview of thermal ablations and hyperthermia. So the initial procedure which has been introduced in I think 2 decades before was radio frequency ablation or RFA. The mechanism of or the technique of RFA, microwave ablation, and cryoablations are similar. We just had to put the needle within the tumor under image guidance, but the mechanism is different. So in RFA, after inserting the needle, that needle produces the radio frequency, and it induces the ionic agitation, and RFA require the grounding pad to close the circuit and to transmission of the waves. So grounding pads usually applied over the thigh or the trunk, And one of the disadvantage of RFA was it increases the risk of heat sink. It means if there is a vessel near the tumor, so the heat produced by the needle is absorbed by that blood vessel and blood, and the efficacy of the treatment has reduced. To overcompensate or to reduce the risk of that complication, microwave ablation was introduced, I think, in 2010 or 15, and it has a faster heat production as compared to RFA. It can generate higher temperature, and there is a reduced risk of heat sink. Another thing, in microwave ablation, there is no need for grounding pads, which is actually painful for the procedure to stick the pad, and after detaching the pad, patient may feel irritation and pain. Third mechanism is cryoablation. Again, the technique is same, inserting the needle into the tumor, but the mechanism is comparatively different because RFA and microwave ablate the tumor by increasing the temperature. On the other hand, cryoablation ablate the tumor by reducing the temperature or by freezing temperature. Cryoablation, one of the advantages that it has less post-procedure pain as compared to RF and microwave. So HIFU, or high intensity focused ultrasound, it is actually a non-invasive mechanism similar to simple ultrasound, and it uses the high frequency acoustic energy, and it has a promising role for pain palliation. Next one is hyperthermia, and hyperthermia is the introduction of sublethal temperature into the tumor region to sensitize the tumor cells for cytotoxic agent. Hyperthermia can be used in combination with other treatment like radiation therapy and chemotherapy, and it enhances the effectiveness of these treatment, potentially leading to better outcomes and overall survival rate. Now comes to the individual tumors. So talking about the HCC is the sixth most common cancer and third leading cause of cancer death. The management criteria is very simple. For localized disease, for early disease, along with resection and transplantation, we can also offer ablation with similar results. And for advanced disease, TACE, TARE, and systemic therapy can be offered. Ablation can also be performed for liver metastasis, especially for colorectal carcinoma and from renal carcinoma. So the hepatic cancers outcome, so RFA best result in tumor, especially for less than 3 centimeter in size, and the tumor must be 2 centimeter away from the major vessels. For microwave ablation, results are similar to RFA, but lower local recurrence, especially the tumor near the major vessels, because of the reduced heat sink effect. Combination of treatment can be done in some cases, and in combination of treatment, we can do TACE along with RFA in a single setting, and it improves the necrosis of the tumor and prolongs the progression-free survival. The limitation of ablation include the incomplete abrasion and recurrence near the major vessels or bile duct, but this limitation has almost obsoleted after the advent of microwave ablation. This is actually the microwave ablation or any ablation system. It includes the needle, which under ultrasound guidance we have to insert at the center of the tumor. This is the wire which is connected with the generator, and these are the knobs, and this is similar to this, not exactly like this, but this is similar to this. There is a chart available along with the microwave system, and after initial assessment and measuring the size of the tumor, so according to the size of the tumor, we have to calculate the voltage and the duration of ablation by this chart. So this is the case of hepatoma in right lobe of the liver. Under ultrasound guidance, the needle was inserted at the center of the tumor. This is the needle, and the ablation start. This is showing the heat production, and at the end of procedure, the tumor size has shrinked. This is another example of solitary hepatoma in left lobe of the liver. This is pre-procedure CT scan, which is showing intense enhancement, while in post-procedure CT scan, the enhancement has completely gone, indicating the successful treatment. This is another example of multicentric hepatoma performed simultaneously by inserting separate needles in different lesions. And at the end of procedure, there is complete ablation of these enhancing lesions. We can also do multicentric hepatoma ablation by single needle to reduce the cost. So this is the hepatoma ablation by cryoablation. Already been mentioned, the technique is same, just inserting the needle and connected to the generator, but the mechanism is different. This was the RFA of right lobe hepatoma under ultrasound and CT scan guidance. And this is the combined treatment. Initially we did TACE, and after the deposition of lipoidal, under CT scan guidance, we inserting the microwave needle at the center of the lipoidal deposition and performed microwave ablation too. So for pancreatic cancers, so fourth leading cause of cancer death with very bad prognosis, only 15 to 20% eligible for surgery at the time of diagnosis. Locally advanced disease, invasion to the mesenteric vessels. So pancreatic cancer has high pain burden and need for palliation. The role of IR is to relieve the symptom, delay the progression, and improve the quality of life. So we can do RF and microwave for pancreatic cancers, improve the survival in locally advanced disease, and mean survival is 25.6 months versus 16.7 months with only chemo. RFA and microwave require precise needle placement to avoid the duodenal and pancreatic duct as well as major vascular injury. High intensity focused ultrasound can be performed for pancreatic cancer, but just for pain relief and enhance the permeability of adjunct treatment. The risk of pancreatic ablation is GI perforation, pancreatitis. This is a case of pancreatic tumor, enhancing lesion in the head of the pancreas, which was successfully ablated by microwave ablation under CT scan guidance. This is another example of infiltrating pancreatic head tumor, and follow-up study after 6 months shows no residual enhancement. So this is the endoscopic ultrasound guided ablation of pancreatic lesion. For endoscopic ultrasound, there is a longer needle which is also available for microwave ablation, and via endoscopically the needle was inserted into the center of the tumor, and the mechanism remains same. It is connected to the generator and induces the specific voltage and time duration. So for biliary cancer, so cholangiocarcinoma is increasing incidence. It has a complex nature because of the anatomy, late presentation, vascular involvement limit the resection, and higher recurrence rate even after the surgery. So endobiliary radiofrequency ablation needle is now available, and it ablates the tumor within the biliary or bile duct. RFA can shrink the tumor mass, potentially making it easier to manage or more amenable for other managements. By reducing the tumor volume, RFA can help keep stent open for longer duration of time, which is important for bile drainage. Some studies also suggest that RFA can improve the overall survival, especially in patients with extrahepatic cholangiocarcinoma and ampullary cancer, particularly those without distant metastasis. Intervention radiology also offers percutaneous biliary drainage and stent placement. So this is the system of intrabiliary RFA. This is a long needle and with 2 electrodes. This needle should be inserted by percutaneous puncture of the bile duct, like this is the case. This is a cholangiogram which is performed showing a tight structure at the proximal CBD, And after puncturing the intrahepatic duct, we pass a needle into the duodenum, and over the wire, we inserted that RFA system across the structure and then ablate the tumor. And post procedure, see the structure has gone. So comparative effectiveness for HCC, RFA versus resection equivalent for solitary tumor, especially for less than 3 centimeter. And RFA plus TASE has greater tumor necrosis with fairly good result as compared to individual treatment. For pancreatic cancer, ablation has fairly good results similar to the resection, and HIFU plus chemo versus chemo alone better outcome as with HIFU plus chemo, and improve the pain score and prolong disease-free survival. For biliary cancer, RFA is far superior than stenting alone for longer stent patency and fewer intervention required like balloon plasty or for restenting. Technical consideration for intervention radiology. So imaging modality, the selection of imaging modalities is very important. Ultrasound is actually the first line of imaging for needle placement. But CT can also be used, especially for obese patient and patient with ascites, because in those cases there is a reduced penetration of ultrasound. Adjuncts include the artificial ascites or nemodissection for the protection of vital structure, like this is the hepatoma, which is very near to the diaphragm. We just insert the needle between the liver and diaphragm and inject a normal saline. This is called hydrodissection. It pushes the liver away from the diaphragm, and after inserting the microwave needle, ablation was performed without any complication to the diaphragm. So limitation and challenges for IR. So anatomical constraint, proximity to the GI structure and proximity to the major vessel has a limitation for intervention radiology procedures. Heat sink effect can prevent the complete necrosis. So in that case, microwave should be preferred. Tumor biology, poor differentiation and multifocality increases the recurrence rate, and cost and availability, especially for HIFU. HIFU is a very expensive modality. And combined modality therapy is, of course, when we combine the TASE along with microwave, is expensive as compared to the individual procedure. So the future directions, AI and robotics, precise needle placement and real-time feedback, and image-guided drug delivery include the thermosensitive and liposomes and nanoparticle. Few of the, these are actually the drug beads. Some of them are available in Pakistan, and we are doing tests via those beads. So in conclusion, VIR plays a central role in treating and challenging the hepatobiliary and pancreatic cancers. Ablation and hyperthermia improves the outcome in carefully selected patient. Increasing evidence support combined modality approach, and need for multidisciplinary collaboration and continued research. Thank you.
Thank you, Dr. Junaid, for taking us few things that we see less frequently as surgeons. Okay, now I request Dr. Om Parkash. He's the consultant gastroenterologist, associate professor at Ahar University. He has trained himself into the advanced therapeutic endoscopy, including ERCP and EUS. And again, we work together on so many things to give the best possible care to our HBP patients. And he's going to talk about the role of therapeutic interventional endoscopy in HBP cancer. So Dr. Om Parkash, please.
Thank you, Dr. Rizwan, for this invitation in a very august forum to give this talk. So, so now I'm left with just a few minutes to complete my talk. But as you know, the Junaid has said they play the central role. Now, I feel like we play the central role, right, as a gastroenterologist, as the future is evolving. I just did the ChatGPT while coming here, just right now, that what is the role of GI in the presence of the IR and the surgeon. And the ChatGPT is saying that when the GI started doing surgeries and IR work, The OR staff whispered, we thought that he just did the colonoscopy, and now he is resecting the tumors and placing the stents like it is cooking a shoe. So let's see what I'm going to see. Yeah. So, so the field is evolving very rapidly, and we are playing a very, very central role, right? And you know that most of these cancers, when they're reaching to the surgeries, most of the time they are unresectable. So the talk itself, the title itself, it's a big conference itself. We can't cover in just 20 or 15 minutes talk. So I just will touch upon the few. So disclosure, I have nothing to disclose. So I briefly touch upon the biliary cancer, pancreatic cancers, and the role of endoscopy in liver cancer, but I will skip it most of the time. But most of these have been covered by the IR people as well. So now, as you know that in the last few decades, as the general surgery has evolved, similarly, the endoscopy has significantly evolved to the extent that, we have, sorry. So as surgery has evolved from the bigger surgery to the minimal surgery, similarly, the gastroenterologists have come from the colonoscopies and endoscopy simple into the therapeutic intervention. And then now we are playing the definitely with therapeutic and even definitive curative intent endoscopies in these hepatobiliary pancreatic surgeries as well. So, so the gastrointestinal endoscopy has long been a reliable backbone in the diagnosis and management of the hepatobiliary disorders and their complication as of now, but now it has gained the therapeutic role as well. The growing interest in the advanced endoscopy has also opened a new novel diagnostic and therapeutic avenues for patients with HBP disease. The integration of advanced endoscopy within the practice of hepatologists there's a new term is called as an endopathology, which is coming up nowadays especially when we are dealing with the liver transplant or the liver cirrhosis patients. So it's called an endohepatology. It's a big field itself. So now we'll talk about first the biliary neoplasia and where we stand. Either we are in the center or in the periphery, but yes, we all play as a team and we play the role here. So you have divided into the biliary neoplasia into the ampullary adenoma and the biliary cholangiocarcinomas. Unfortunately, you know that these are the diseases which usually we left with a few therapeutic intentions if they are lucky enough to find out early. And this is just bookish presentation of the biliary neoplasia, so I will just move on to the diagnostic. We have a significant role in the diagnostic nowadays. Previously, we rely on the ultrasound and the CT and the MRI. Serology has a plus minus role. But yes, CT and MRI has some role, but after the introduction of the endoscopy has again changed the dynamics of the management of these cancers. Again, coming back to the ampullary adenocarcinoma, this is just classical rare tumor. 20% of the distal CVD obstruction is most of the time is ampullary carcinoma symptoms, again jaundice and the constitutional symptoms. They come up with the ultrasound, then we go to the CT and MRI, and then they give us the reasonably good information that where we stand and how to. So as a gastroenterologist nowadays, we have the endoscopies, which provides care in terms of the management of the patients. It gives us the diagnostic, it gives us the local staging that will help in planning the treatment as well. So CT is more sensitive and accurate, but overall accuracy is still low in terms of the maths as well. So here our role comes in. Either we do with the ERCP or EUS. The first I will go with the ERCP. If the malignant obstruction is suspected, it is recommended that patient should undergo the ERCP. This helps with the better visualization, biopsy for the histological diagnosis, and state placement when feasible. Then again, it depends what kind of a patient that you are dealing with. Not necessarily most of the time we end up in doing the drainage, we just do the biopsy and come out and then go for the resection. Similar to the CT scan, the ERCP is also not a good choice for imaging modality for perioperative staging. So procuring the tissue at least 48 hours, so that is the only indication. But after the introduction of the EUS, it has again changed. So it has become the prerequisite for the, the pancreatobiliary. So here the role of the endoscopic ultrasonographer is very much important, that it should routinely performed in such patients. Most accurate modality for T staging and at almost more than 90% of the patients. And transpapillary endobiliary stenting decreases the, so most of the time, the people as a gastroenterologist also, as number of gastroenterologists are increasing, the experience is not the people, when they get that patient and they immediately without MDT discussion. They just do the ERCP and then they put the stent in just to relieve the obstruction without knowing that. And that is where we end up in a lot of disasters, and we see that this is not the good thing to do the ERCP. Drainage is not essential. That should be the message should be given even to the gastroenterologist. So drainage is not important, diagnosis is more important. Drainage you can achieve later as well. We have seen the disasters in this. When you put this stent in, you can lose the sensitivity of the diagnostic modalities, and you can lose the hidden tumor there, and then subsequently with the passage of time the people can become non-resectable, right? So that is where our role is important. So do the US properly, drainage is secondary. And then the therapeutic role, we as a gastroenterologist now evolved to the extent that the ampullary tumor can be resected without going for the surgical resection. So that is coming up now. It is the now standard of care in certain centers. Like, of course not here, but yes, hopefully soon we will be getting that thing. So the cholangiocarcinoma, again, it's a very challenging thing. So it's a relatively common disease here. We do see in a center where we see the pancreatobiliary cancers. And again, depends, it is divided into 3 zones. And each zone has a different management. It is not like that the standard treatment that you provide them. Is it an intrahepatic, is it a extrahepatic, or is it a distal? So each area has a different treatments. So this is the famous Bismuth classification that helps you how to deal with those people and how do you drain them, right? So the ultrasound and CT can suggest you, but MRCP has an additional advantages. MRCP give you 70 to 80% sensitivity for diagnosing the cholangiocarcinoma. MRCP give you the strictures that it is, if it is more than 10 millimeter length, then it irregular, then it suggests cholangiocarcinoma. But after the introduction of the EUS, if it is a distal, then EUS should be the standard for diagnosing such cases. So that is where, the role of endosonographer is more important in these types of patients. So the ERCP, traditionally when the EUS was not there, then you used to do the ERCP. Again, nowadays, ERCP alone should not be sufficient if you have a cholangiocarcinoma. So it's better to combine that ERCP with the cholangioskopy. You can directly go inside and do the biopsy and directly examine that thing, and then that will help in determining the, rather than just putting the stent in. So you can directly get the biopsy there and then. So now a therapeutic role of the ERCP in the cholangiocarcinoma, as Junaid talked about that, you can, there are catheters which are IR available, but these are, we say these are, less invasive. You can go inside, you doesn't cut the skin. You go through that, they are easily available. Not here, but it's coming up now. The Korean company has come, they are marketing it. It is just our fear from the patient side and our sense. So that will gain experience once we start getting those patients. So this is a recently randomized controlled trial that shows that who underwent the photodynamic therapy, and it has shown the patency rate, overall survival has improved. And so these are the patients, otherwise you can think of going for the liver transplant in these patients. So it offers a number of practical advantages, as it is minimal invasive, has a low complication rate, procedure can easily be performed by a skilled endoscopist, and it is well tolerated. Patient can go home in the next day. Again, the cholangoscopy, as I talked about, again in the cholangiocarcinoma, it is the basic investigation or the modality that you can consider in these types of patients. So the drainage, as I've mentioned to you, the drainage is not important, the diagnosis is more important, and the area of the cholangiocarcinoma is again more important. That will determine the future treatment. And it has the cholangoscopy has a reasonably good sensitivity, so even on just looking at the lesion. And there are certain characteristics of those lesions that you can see with good sensitivity, and especially you can say this is malignant or non-malignant. So again, the role of the EUS has a significant role again for the cholangiocarcinoma, especially in the distal or mid CBD structure, but higher you cannot, but yes, it can be picked up. You do the EUS, if you found the lesion, do the biopsy, you can get the diagnosis there and then. And so that is the diagnostic role of the EUS. Again, so you see the algorithm of the EUS, so the cholangiocarcinoma. So every one plays the central role, depends upon what stage of the patients that you are getting in. If it's early enough, then of course the surgery is important. If it's not early, then the VIR or the gastroenterologist plays significant role, depends upon what. But VIR role is, with the passage of time, as a gastroenterologist we say, is decreasing because of the endoscopic better interventions. So again, these are the bismuth classification and how do you approach them. If you see that if it's stage 1, then 1 stent can suffice the whole drainage. And if it is 2, then sometimes the stage 1 stage can cover these things. But the problem comes when it is 3 or 4. Then it is either you do with the ERCP or you do with the EUS as well. So here again it comes with, the PTC or PDPD is going obsolete in the waste, but here is still because we are not to that level. But in future, of course, the role of the IR will significantly reduce in these types of patients where we can achieve these drainage procedure endoscopically. So you can see that, here if you put either 2 stents or you can go 2 ways. Again, the stent on the right system, and then you can do the US guided hepatogastrostomy. Even hepatogastrostomy, you can put the one single stent that will cover the drainage of that thing. And you know that the distal distal cholangiocarcinoma can also cause the gastric outlet obstruction, that you can also do the gastrojejunostomy with the US that I will talk about. Now moving back to the pancreatic cancer, we talked about, we have learned this pancreatic cancer too much about basic things. It's a very lethal cancer. 5-year survival is around 13%. It is growing, and we are also seeing the large number of patients here as well. So so diagnosis, typically we all know, so we can skip that, but the diagnostic, we read about the CT, MRI and ultrasound, but the role of the endoscopist has increased nowadays. It is the essential role. Without the US, no pancreatic cancer can be touched. So that is where, again, we play the very, very vital role in the management of the pancreatic cancer in terms of the diagnosis. And it also increases the role towards the therapeutic as well. This is again US for the pancreatic cancer that will help us in the T staging, and sometimes it also gives you the accurate vascular involvement that you can sometimes miss on the imaging, right? So that is where the US is very much essential. So again, in terms of the treatment of the pancreatic cancer, again, either you're talking about the therapeutic intent, or you're talking about symptom relief, or you're talking about the palliative intent. So each area we have a role in that thing. So number one, if it's a biliary obstruction with cholangitis, you go and do the biliary drainage procedure, either ERCP or EUS. But nowadays, in 99% of the time, if it says that the PDB should not be done, it should be the endoscopic drainage, either ERCP or US guided biliary drainage should be done. Because the IR has a, like VIR, PDBD has a higher risk of infections, higher risk of morbidity, but with these endoscopy, you can see approach, where's that? You can approach the bile duct from multiple areas. You can approach from the stomach, you can approach from these are the US guided intervention if your ERCP fails. So you can, there are multiple 4 gates to reach to the CBD, right? So we talk about that. So that is why all the international societies now recommend that US is the essential part of the pancreatic cancer management. So again, the ablative therapy Dr. Junaid talked about, that is again, we are eroding into those areas as well. We have developed those catheters and we are doing those interventions, not here, but yes, hopefully soon you can see that the therapeutic as well as palliative care management. Drainage in the pleurisy, I talked about that. Relieving in the gastric outlet obstruction, we will talk about that. The chronic, the pancreatic cancer has a significant pain that can be managed endoscopically. Chronic pancreatitis pain can be managed endoscopically. Similarly, RFA previously used to be done by the VIR guy. Now, these catheters are available which we can pass endoscopically and take care of those things. Similarly, fiducial markers, SBRT, radiotherapy, the people who needs radiotherapy to give the accurate dose at accurate place, you place those fiducial placements. That is where again the role of the gastroenterologist comes. And there is a direct delivery of the chemotherapeutic agents, like this concept comes from the radiologist where they do the TACE procedures or the chemotherapeutic procedures directly implanting into the tumors. So then again, the relieving the obstruction, pain control, how do we end that? There's plenty of data that is available. So these are the gates that I told you that how you drain these biliary obstruction when they come to us. There are multiple gates now we can approach. Bile duct, you can approach this gallbladder, you can approach the left biliary system, you can do the pancreatogastrostomy with the US guided. These are the different procedures that they are available to relieve the obstructions, right? These are the multiple studies now available with excellent and robust results, and meta-analysis have shown that they are the best, yeah. So this is again one of the study that shows the ERCP versus USBD. So there's again USBD is showing better results. So this is again in patients with the gallbladder drainage where you can't achieve the biliary drainage from them, then you can drain the gallbladder. So this is another study that shows that significant improvement with that, with significant not with significant decrease in the morbidities. And then the which gastric outlet obstruction, you can do the gastrojejunostomy bypassing the gastro. So this is the route that you achieve. So you pass the guide wire, go into the jejunum or ileum, and then you can do the gastrojejunostomy. The problem is the cost here. You know, majority of the patient cannot bear these costs. The cost of these stents are very, very expensive. Hopefully the cheaper version will come and that will help us, because the next day patient can go considering the surgery, doing the surgical gastric bypass versus the endoscopic bypass. So this is again meta-analysis, and then that shows that the US gastrostomy or US gastric bypass are better than the surgical, which has got the better outcomes in terms of the morbidities. So again, the pain, we talk about the pain management. So we send to so here's a significant, you can do under direct visualization the neurolysis of this pain, and the pain can be managed. That is a palliative role that we can provide. Again, the same neurolysis, the meta-analysis again shows that it is a significantly better outcomes and better results. And chronic pancreatitis pain management, again, the role of the radio frequency is coming up. The data is from the South Korea, and they have developed that machine which is available in Pakistan. We have seen that the demo. A couple of cases is done in Pakistan, not by us, but some of the people have done in Islamabad particularly for the neuroendocrine tumor, which has got the good results, particularly for the neuroendocrine tumor up to the size of 2 centimeters or 3 centimeters, where it can be ablated. So this is the machine. So maybe I hope it's the same machine as the VIR guard has, but the needle is different from the VIR people. So again, RFA, we talk about that thing, so I'm skipping that. So it is a significant role we are providing. I think the font has, it's a software issue here, that font is changed on its own. And US guided RFAs are being now, there are studies available which has done the RFA in the pancreatic adenocarcinoma as well, which are locally done. So again, resectable tumor, there's the fiducial marker placement that can also be used for the pancreatic cancer management and where they need the radiotherapy, right? They can easily be placed. There are different types of the fiducial markers which are available. They are easily, that procedure can be done in 10-15 minutes time. And multiple studies, multiple types of things available. So this we can go anywhere in. So this is where we stand in management of the pancreatobiliary cancer patients. So in conclusion, ERCP has evolved to include the cholangiopancreatography, tissue sampling, and drainage treatment, making it a crucial role. US and related modalities again being used from the screening, diagnosis, therapeutic, and the surveillance as well. Again, US versus combined ERCP, USA RFA, yes, it could serve as an area of promising future direction in the management of the pancreatic malignancy. Thank you.
Thank you very much, Dr. Om Parkash. We had plans to present a couple of case discussions here, but our speakers have been very, very enthusiastic in their talks, and so I'll hand over the microphone to Professor Mushtaq Ahmed and Dr. Abdal. Please, sir.
Are there any questions that for the speakers?
Any questions, please?
Maybe I can start with Dr. Jahanzaib, who presented a very comprehensive and clear picture whether to resect HCC or to transplant. In our experience, we have seen that alpha-fetoprotein in Western literature is 80% positive in HCC, but we find it less than 50% positivity. And therefore, I don't know what are your thoughts on this, and whether PIVKA2 marker is coming up, and should we be using that instead of the alpha-fetoprotein, which is negative in more than 50% of the cases.
Thank you, sir. Definitely, we have a number of patients. Okay, I would like to say that 50% of in our population they are AFP negative, and now PIVKA is now being rapidly evolving over the period of 3 or 4 years time. Now we are at the liver transplant unit. We offer both